Thank you, everybody, for joining. This is a very important topic, and we're very excited about this. Return to work after having a stroke, some sort of a cardiac event, or cardiac arrest is a serious issue that we've heard from all of the people we work closely with who've experienced these events is one of the biggest stressors for them in so many ways, because returning to work represents their own personal self expectation and perception of themselves. Not being able to return to work can create financial hardships for their family. There's many aspects to this, so we're very, very grateful for our presenters today, and the overwhelming response. The registration for this particular webinar was among our highest ever, so thank you, everybody. I'd like to introduce our speakers. Our first speaker is Dr. Alan Garland. Alan is a professor of medicine and community health sciences, and he's head of the section of critical care medicine at the University of Manitoba. Dr. Garland is a heart and stroke funded researcher, and he led this very, very landmark research study that just got published with great media interest a few months ago, looking at the long-term effects of cardiovascular events on capacity to go back to work and changes in their annual income. There is tremendous information that we have never had before quantified in this way, which will be very helpful to all of us as we move forward and support people who've had heart disease and stroke. We're fortunate, after Dr. Garland talks to us about his research, to then get down to the practical. So what does this mean to all of our healthcare providers, regardless of what your role or setting is, in terms of answering questions from your patients about returning to work and how to help them, if that's their goal and intent, how to help them work through the process to actually get back to work. So we're very fortunate to have two gentlemen, Samuel Kim and Gerard, and both of them work for a program called the Community Accessible Rehab Team in Edmonton. We're very envious of these guys because not every province and not every community has this kind of a team where people are focused on helping you get back to work. So Sam's note is been working with the CAR program, since 2010. He's worked in vocational rehabilitation at various points in his career. He is an occupational therapist, and he has been a key player in this role. Gerard has worked in the area of vocational rehab for 33 years, so great experience to bring to all of you today in our webinar. He's worked both in the private industry and in insurance and in private practice and now within health systems. So we're grateful to all our presenters, and we'll turn this over to them shortly. Just a reminder, the objectives of today's program are to really explain the impact that stroke and cardiovascular events have on an individual's work and earnings. What are the relevant issues around returning to work that people experience? And then what kind of assessments and practical tips can we provide you so that you can help your patients move forward? So with that, I'm going to turn it over to Dr. Garland to start his presentation.
Okay, thank you very much. So greetings, everybody. I'm going to tell you about the research that we've recently completed. Okay, thank you. All right, so there's my disclosures, not really much other than research grants. Okay, so obviously strokes are not only life-threatening, but also life-altering among survivors. It turns out that the ability to work and earn, which we include under the rubric of labor market outcomes, are quite important at patient-centered outcomes for working-age people. As Patrice said, the ability to work has a lot to do with people's view of themselves. But this topic has been studied relatively poorly in the past because you need reliable data about stroke or whatever your acute health shock is, about work and earnings that are linked together. So Statistics Canada has both of these things. They have the discharge abstract database, which includes all hospitalizations for all causes in all of Canada except for Quebec. And they also possess individual tax returns. And so we link those two. So the study questions were, in this Heart and Stroke Foundation of Canada funded study, how does stroke, and I'll tell you at the end about heart attacks and cardiac arrests as well, how do strokes requiring hospitalization influence the ability of working age people to go back to work and to earn? And also, how do these health shocks influence the work and earnings of spouses and partners? So we linked the data. The substrate for this analysis was people aged 40 to 61 from 1999 to 2014. We chose 40 as the lower limit because there aren't very many heart attacks, strokes, and cardiac arrests amongst people less than 40. Not none, but few. And we chose 61 as the upper age limit because we wanted to avoid running into the usual time that people retire at around age 65. So we linked tens of millions of hospital records with tens of millions of tax IDs. And we linked, in order to link the hospital data to the tax data, we linked on the sex of the person, their date of birth, and their postal code. And these three things alone helped us link 86% of hospital records with taxes, which is pretty good for this kind of large data linkage. So this is a match study. We compared people who had a stroke with others who were similar, except that they didn't have a stroke. So we could try to compare apples and apples. The stroke cohort were people hospitalized from 2008 to 2010 for stroke. We call the year of the stroke year 0, Y0. And they had to have tax data from 2 years before, Y-2, all the way up to 3 years after. So these were survivors. These were people who survived at least 3 years, 3 full years after their stroke. So, and we, in order to look at this, we looked at people who were working according to the tax data in the year before and 2 years before their stroke. So we included in this Canada, all of Canada except Quebec and the territories. Now for the control people, we had people who were similar to the people with stroke, except that they didn't have a stroke. Now, we had two primary outcomes here. One was the difference in total income between the year before, Y-1, and 3 years after. So the change from before to after the stroke. And then the second outcome was the percentage of people who weren't employed 3 years later. Remember, everyone in this cohort was employed the year before and 2 years before. So the way this analysis works is a sophisticated statistical analysis, and I'll describe it in the following way. On the x-axis there, you see before the event, the year of the event, and then after the event. And imagine that you have somebody who had the event. So from before to after, so the y variable here, let's say, is income. So their income fell. So you see that vertical height, what we call A, is the pre-event versus post-event difference for the people who had the event. But that's not the whole story, because here's somebody who didn't have the event, for instance, and they also had a drop. Their drop was B. Now, if you just looked at A, you would over-measure. The height of A is greater than the difference in the pre to post change in income due to the event, due to the stroke. The actual pre to post change due to the event is A minus B. It's called a difference in difference analysis. And that's what we did. We had cases, people who had the event. We had people who were very similar who did not have the event. And we subtracted B from A to get the magnitude of the effect due to the event, which in this case is a stroke. Now we can do even better if the cases and controls are as similar as possible. And we matched them on 11 variables. After all, we had all Canadians to choose amongst. So we were able to find a large number of control people who were very, very similar to the cases, except for the presence of the stroke. And I'll just let you look there. I won't read these variables, but there are a lot of important variables, including their actual earnings in the year before and 2 years before. Okay, so this is the cases. We had 4,398 people with strokes who met our criteria, survived 3 years. We matched those to 888,695 people who were similar but didn't have the stroke. And you see that the mean age was, in the year of the event, was 53, and you see that about 35% were female, and their characteristics are very, very similar. And the reason they're similar is that we matched on those characteristics. The Charlson score is a measure of comorbid illness, and the things on the bottom, the 5 items on the bottom, only existed for the cases. So, for instance, hospital length of stay is relevant for the people who were hospitalized for their stroke, okay? But it's not relevant for the people who didn't have a stroke. MV is the percent who had mechanical ventilation, which is a form of artificial life support. 6% had that. 22% were admitted to an intensive care unit. And just for interest, of the total strokes, 14% of them, I'm a minority, were bleeding strokes instead of a blockage type stroke. Okay, so those are the characteristics of the people. And here's the results. You see on the left the fraction employed, and you see along the x-axis the year. So in the year before, y minus 1, and 2 years before, by design, everybody was employed, 100% of them. And you see that in the open circles, the people with the stroke, it fell dramatically. And you see that it also fell in the controls, but not by as much. The difference between those two curves, I think you can see this, the difference between this point, which is around 88% working, and this point, which is around 68% working, this distance here, vertical distance at 3 years after the event, is the difference attributable to the stroke. And we can see something similar in their yearly income. We see that they started out, both groups started out with a yearly income in the high 40,000s. And 3 years later, the controls were making about 42, 43, but the people with the stroke were making much less, more in the high 20s. So this is the magnitude of the effect. So this is just looked at in a different way. The difference between, at 3 years, the difference between those two groups in terms of percentage working was almost 20%. So there was a drop at 3 years after their stroke. Of the people who had the strokes, 20% fewer were working than the people who didn't have the stroke. That's a big difference. And their fall in income was an average of $13,000 a year in 2012 dollars. Now, of course, some of those people who had stopped, some of those people, when you look at their yearly income, some of this 13,000 fall was due to some people who stopped working altogether, and other people who kept working. And the question, one of the interesting questions is, was the amount of, for the people who were still working 3 years later, did they lose income too? And the answer is yes. They lost less than the average of 13,000, but even amongst the people still working 3 years after their stroke, their mean decline in income was $9,300. Quite important. Now we also looked to see if these effects differed, and they did. People who were of older age when they had their stroke had a bigger effect on their labor market involvement. People who had more chronic illnesses, those who during their stroke had a longer stay in the hospital, which might indicate that they were sicker with their stroke. Similarly, people who needed to be admitted to an intensive care unit or required artificial life support, all of these people had a greater effect than the average I show at the top. Interestingly enough, there was no difference between men and women after adjusting for their characteristics. Okay. We also went further and looked at the work and earnings of spouses and partners. This paper is under review but has not yet been published. Now, prior studies have tried to look at this, and they found that there was, on average, no change. But we reasoned that maybe the reason, on average, that there's no change is that some spouses or partners actually stop working in order to take care of their sick loved one, and maybe others start working or work more to counterbalance the loss of income of the loved one who had the stroke. And so we thought that there might be no average difference because the ones that rise and the ones that fall cancel each other out. So we looked at it in a better way. We analyzed spousal work and earnings from the year before to 3 years later. We matched the case and control now as couples on a bunch of variables. And unlike the people with the stroke, we didn't require that the spouses worked before the stroke occurred. We had 11,000 matched couples. That is couples, one of whom experienced the stroke, with other couples, neither of which experienced the stroke. And here's their work transitions. Now, if you look at the ones in colored bars, in fact, you see that the 2.8% of spouses who weren't working before, 3 years later, they were working. And 7.8% of the spouses who were working before their spouse had the stroke were not working 3 years later. So this seems to suggest on the face of it that in fact our thought that some go up and some go down and maybe the average isn't much of an effect might be true. However, now look at this. When we looked at the same percentages for the spouses of controls, people whose spouses did not have the stroke, it's almost the exact same percentage. So although there were increases and decreases in work amongst the spouses of people who had strokes, there were equal increases and decreases amongst the spouses of people who didn't have strokes. So there's no effect here that we can attribute to the strokes themselves. And we did the same for actually the change in income of the spouses. So we see, for instance, look at yellow. So the percentage of spouses of people who had strokes who had a more than 50% rise from the year before to 3 years later of their income was almost 10%. And about 9% had a more than 50% fall. Well, that looks like it confirms the previous thought, except that those percentages are almost identical to the percentages in the spouses of people who didn't have strokes. So again, no effect that we can discern here on changes in income or in the percentage working of spouses before versus after the stroke that we can attribute to the stroke, because the spouses of people without strokes had the same effects. Okay, so quick summary. Strokes led to large, bad effects on the ability of long-term survivors to work and earn. To our surprise, there was no effect on the work and earnings of the spouses. Now, unemployment and lost earnings due to acute health shocks such as stroke or heart attacks have broad relevance to society. It obviously affects the patients, their families, but it also affects employers and governments. Employers have to deal with people who, if they lose a worker, they have to train a new worker, which is ineffective and inefficient. Governments have to pay unemployment insurance, et cetera, et cetera. Individuals, it can go so far as to cause bankruptcy. And in addition, earnings losses can lead to a sort of a vicious cycle where you lose money, and as a result of losing money, you're not able to afford your medicines. And as a result of not being able to afford your medicines, your underlying illness or illnesses could actually get worse, and on and on. So the cost of lost productivity due to people who can't work or can't work as much is large. We've identified high-risk subgroups, I went over that with you, that can help perhaps target interventions and policies and legislation to promote return to work. I also want to show you that we did this not only for stroke, which is on the right of this diagram, but also for acute myocardial infarction, heart attack, and for cardiac arrest. And you can see that the effects are largest for the stroke, intermediate for cardiac arrest, and then smallest but still significant for the heart attacks. So the numbers are these. We saw that about 20% of stroke people, 20% of people due to the stroke lose their ability to work with an average loss of earnings of $13,000. At the other end, only 5% of people with acute heart attack, again, who were long-term survivors, lost the ability to work, and their average loss of income was less, $3,800. And also in these other two, in all three of these, the strokes, the cardiac arrests, and the acute heart attacks, in none of these did we see a spousal effect on work or income. And this is our research group. There's a bunch of people from Statistics Canada and the other researchers listed there at the bottom. So that's all I have to say. Thank you very much. I can't hear.
Can you hear us now?
Yeah, we hear you now.
Very good.
Okay. Good morning or afternoon, everyone. Thank you for the opportunity to share about our experiences in helping clients return to work post-stroke. Just to provide a quick point of clarification, Gerard and I actually work for the Community Accessible Rehabilitation Program that's based here in Calgary, not in Edmonton. Today, we hope to provide insight into our practical experiences in the process of facilitating return to work and want to positively contribute towards the further development of stroke best practice guidelines in this important area. By way of introduction, my name is Sam Kim. I'm an occupational therapist by background, having worked in the area of neuro rehab now for just over 10 years, and I've worked as an OT for nearly 20. I've always been interested in the area of return to work, as I see it as a confluence and collaboration across all disciplines. As far as common goals for rehab, I find that as an OT, two of my most common reasons for referral are to help clients return to drive and to return to work.
And my name is Gerard Curley. I worked in the area of vocational rehabilitation for most of my OT career, and I've seen the return to work process from the viewpoint of the health provider, the contractor, insurer, and employer.
We have no disclosures to disclose. To briefly summarize what we hope to cover over the next 15 to 20 minutes, we are aiming to provide a framework from which to approach answering the question of whether a client is ready to return to work, how addressing the goal of return to work is similar but also different in some key ways as compared to addressing other ADLs and IADLs, and lastly, to outline a practical approach to the process for return to work, from assessment to actual return to work planning, implementation, and follow-up.
So let's just take a few minutes to discuss how return to work might be similar or different from a return to regular activities of daily living. Return to work is similar to a return to activities of daily living, such as dressing and cooking and shopping, in that a thorough assessment of the client and the task is needed. Return to work differs in a number of ways from a return to other activities. Generally, there's a greater risk if the client fails. The risk can be to the client themselves in the form of loss of confidence or potential financial risk. And the risk is also to the employer in terms of physical safety, loss of production. The work activities tend to be more complex than many ADLs, with the potential of having several activities and duties for the client to manage. In helping a client with their activities of daily living, we would tend to discuss the goals with the client and their family. When considering a return to work, there are several different players involved, including the client and their family, of course, the employer, which might include their manager, occupational health and safety, human resources. There's the medical or rehab team, which might include the family physician, specialists, and therapists. And if they're getting support from an insurance company, there's the case manager, perhaps an insurance broker, or their rehabilitation personnel. The complexity of the information can be daunting. And if we see our role as a manager of that information, we must ensure that all parties are well informed.
To build on what Gerard just touched on, for a clinical reasoning model and practical framework, I like to draw upon this picture as a way of conceptualizing how we approach and answer the question of whether someone is ready to return to work. I find it visually demonstrates how the level of risk and complexity of activities ranges and grows as we expand from looking at a client's ability to perform their self-care activities, where the sphere of influence is limited to the individual, and therefore the level of risk might be smaller in scope, up to the second level, where the question of safety involves not only the client, but also their households, all the way up to work, where depending upon the job, the questions of safety and risk need to be looked at from multiple perspectives. Having a clearer sense of a client's level of functioning based on their performance of their basic ADLs, complex ADLs, and managing transportation allows us to better estimate when a client is ready to approach return to work. Given our role in the medical team, we also need to remind clients that even when they start back to work, they need to be able to continue to meet their other roles of daily life, including father, mother, wife, husband, dog owner, volunteer, etc.
Now we talked about all the different players that might be involved in the return to work process. It's important to recognize that all of the players in the process have different priorities. All of them will say, that their key responsibility is to the client's best interest. However, you may find that each player has a different contribution to make. It is the employer's responsibility to offer reasonable accommodations. Now, that's a human rights term or a legal term, and most large employers are quite familiar with reasonable accommodation. Smaller ones need some education on that. But first and foremost, we always have found that employers tend to be most concerned about the safety of the worker and other workers. If an insurer is involved, their chief responsibility is to honor the contract under which the benefits are offered. There are a lot of misconceptions about insurers that perhaps case managers are paid bonuses for rejecting claims and so on. These misconceptions are never helpful to the process, but they can be prevalent. The medical team can include physicians and therapists, both public and private, and the priorities tend to be the client's safety and recovery. And finally, there's the client. In the end, it is they that are doing all the heavy lifting in the return to work process. What may be important to them might include financial security, increased social interaction, or control over their lives.
To provide a general overview of the flow of information when facilitating a return to work, when clients are seen in our program, and it is established that the client is safe and ready for return to work, the return to work plan is drawn up and finalized. Before the return to work plan is communicated to the insurer, the plan is reviewed by a physician to ensure there are no medical restrictions that have been overlooked, and to act as an extra measure of security for the client. Once the plan is signed off by the physician and it is in the hands of the insurer, the responsibility then lies with the insurer to work with the employer to confirm the plan will work and is acceptable from the employer's perspective. In certain situations, the physician may directly communicate a return to work plan to either the insurer or employer. This can be as simple as a notation on the prescription pad stating "OK" to return to work. Though our last slide may make it appear as though information and the process for return to work flows one way, in practicality, ideally, information feedback is a shared process amongst all the players, including the medical team, the insurer, the client, and the employer. But to start back at the beginning, the nut we are really trying to crack is in attempting to answer the question of whether a client is safe and ready for return to work. What we want to bring to your attention today is that this process of assessing return to work readiness is no different than evaluating other client roles and activities. However, though the process is similar, the difference is, as Gerard has already touched on, is that work can be more complex and there are more players involved. One of the keys then is to better understand the client's job demands. In the end, borrowing a term from my wife who works as a project manager, it comes down to a gap analysis. Where is a client and where do they need to be at for work?
Once we have a fairly thorough assessment of the client and what their potential barriers might be, it's important to understand exactly what is expected of them at work. Basically, we are asking, what does the client's job require of them from a physical point of view, a cognitive point of view, and in terms of communication needs? There are a number of ways you can analyze work, and there are multiple checklists available on the internet for analyzing the physical demands of a job. Cognitive job demands analysis can be trickier. The City of Toronto, in their job demands analysis, seeks to describe jobs in terms of both physical and cognitive demands, and you may find their analysis format useful. In our practice, we will contact the employer directly and try to determine through interview and/or observation what the key job tasks are. We then determine the physical, communication, psychosocial, and cognitive demands of each activity. We look at the different components of the work, the meetings that they have to attend, the equipment that they have to operate, the rhythm of their day, their work hours, their level of independence, and the quantity and quality of what it is they produce. We can all define our jobs in terms of the product we produce. It may be widgets or reports or healthy clients or sales targets. By determining what the client is responsible for producing, we can more easily provide feedback about their performance during the return to work process.
When it comes to identifying where the client is at, we count on and pull in as much information as we can. At the center of this collaboration, though, is the attempt to build consensus between all parties, and again, trying to answer the question of a client's safety and readiness for return to work.
In the end, we ask, what is getting in the way of a successful return to work? What are the barriers to success? Are there things that the client themselves has to manage, such as fatigue, distractions, organization of the work? What changes to the work are we asking of the employer? Are these changes or accommodations temporary or permanent? Are some accommodations easier to offer than others? How many hours can the client tolerate? If they could tolerate, say, 25 hours of mixed activity on a consistent basis in the community, including therapy and transportation and self-management, then is it reasonable for them to start working perhaps 12 hours a week in their jobs? Other considerations may include what time of day is best for them to start, for best performance, or to avoid a lengthy commute. From the insurer, we may request special equipment or furniture. We may ask for a length of modified work that is longer than they are used to. In all cases, it's important to be ready to provide a rationale to the insurer and the employer for any accommodation that you ask. The return to work process can stop short of success for any number of unforeseen reasons. The client may see these as a brick wall. It can be our job to give the client a boost over that wall and on to the next step by offering solutions to problems that they might find insurmountable. We would prefer that the return to work process be more of a foot race than an obstacle course, but obstacles often get in the way. I'd like to just offer an example. A client of mine recently suffered a stroke, and as a result, the English skills that he had learned since immigrating from his native Vietnam were compromised. Before he could return to work, he was required to pass a computer-based English safety course. Every time that this was brought up with the client, he became more and more anxious, and he just couldn't see a way around it. In discussing it with his employer, who viewed him as a valued employee, they came up with the solution of offering a translator to help him just translate the questions. This is a simple example, but the client was ready to stop the whole process, and without some intervention, it would have stopped.
Now that we have an appreciation of the client's functional abilities, their job demands, and have identified their barriers for return to work, it's time for us to summarize our recommendations clearly to the insurer and or the employer to overcome these barriers. This takes the form of a return to work plan, which is typically a letter. Though the length can vary, usually it's only a couple of pages long. This correspondence will include a gradual return to work schedule outlining hours per day, days per week, total number of hours worked per week, and some method of adjusting the return to work schedule as needed. Accommodations may include hours of work, a quieter work environment, or having supervisors relay instructions via writing instead of verbally. Other commonly requested modifications include having tasks be assigned one at a time, rather than being asked to respond to multiple tasks all within a short time frame.
Restrictions, from our viewpoint, tend to be more physical in nature, but they can include any activity that the client should avoid. This is just important to communicate to the employer and insurer. It is vital that the client's progress be carefully monitored as they go through the gradual return to work. Depending on the client's needs, we would tend to set up a regular schedule of meetings with the client and employer. As much as possible, there should be tangible expectations that the client can meet, keeping in mind that by the end of the return to work, the client may be expected to fulfill all of their own job requirements. Again, you should be prepared to offer rationale for any recommendations that you make. A word about consent. As we were saying, it's important to communicate openly across all parties while still respecting the client's privacy. For this, we ask for two separate consents. One for the employer, which would cover return to work recommendations, restrictions, and accommodations, and one for the insurer, which would cover all return to work recommendations plus all relevant medical information, including diagnosis, symptoms, and treatment. In conclusion, I think we have endeavored in our practice in Calgary to incorporate the key tenets of the stroke best practice model. We would stress that very specific and detailed assessment of both the client and their job is required. The contributions of all players, but especially the client, need to be respected. It's important to know the role that each participant plays, what their priorities are, and how this is important to the client and the entire process. Return to work will continue to be a major goal for our clients, and getting them there can seem arduous. However, with thorough assessment of the client and their job, careful planning, and clear communication and collaboration with the employer and the insurer, a return to work can be achievable.
Thank you.
Thank you.
Fantastic. Thank you very, very much, everybody, for those presentations. They were great. Lots of information. So we'll open it up for questions now from our audience. Just to let you know, we've had over almost 420 people, 420 lines open on this webinar. So that's an amazing, and we know that in many places there's multiple people watching together. So quite an interest. Questions, please, for all of you in the audience, enter your questions onto the question box on the computer and we'll get to them. So there are a couple and I will get started. The first question is for Alan. So Alan, in your study, it was surprising to hear that there was no sex differences. And one of the questions that we have is, we know that a lot of the onset of stroke and some heart conditions for women tends to happen at an older age than men. In your analysis of sex, was there an analysis that looked at sex by age to see if in younger populations there was a sex difference?
So we looked at heterogeneity by age and by sex separately, but we didn't look at it by sex by age. So you're right that it is conceivable that that some interactions, that there could be cells, some subsets of people for whom there's a difference. So we did not look at that.
Okay, is that something that may come in a future study?
I mean, we have the data. We're not currently planning on doing it. I should say, just for people who are interested, that this data exists at Statistics Canada, and the data linkage of the discharge abstract database to the tax data exists, and anyone can use it. Now, it's not free to use it, but that data set is part of what we used, creating that data set that is now at StatsCan and available for use by other people, is one of the things that the money that we got from the Heart and Stroke Foundation of Canada enabled us to do. So, for instance, we ourselves have also done a similar analysis looking at severe trauma, and I know that there's somebody in Edmonton who wants to do this for kidney failure. So I say that to say this: we personally aren't planning on doing that, but this data set's available for others to use and to do additional research and additional analyses.
Great, thank you very much. Sam and Gerard, there's a bunch of questions coming in for you right now. The first one is one that I'm actually going to ask. I've had, in my role, I get families calling me, and I had a situation where a family called and said their father, a woman called and said, my father's really anxious to go back to work after a stroke, but we don't want him to. Is there some way to intervene and stop him? Do you have any situations or advice to people where the family pulls the healthcare provider off into the corner and says, I know he's talking about work, but we don't want him to do it? Can you talk a little bit about that and where the health professional should be in that situation?
Yeah, I think that in those situations that we've had, and we've come across that not a lot, but certainly a number of times. We always stress that our role is to make sure that you can safely go back to work. If there's concerns because of results on neuropsych testing that the client doesn't have much insight into their into safety concerns, for example, or limitations, we would tend to sit down and say this does not seem like something that you could safely do, and certainly our role would be to back off from that, from any kind of return to work planning. But it can't. It sometimes just can't stop people from going, and that's, we have had people go back that didn't succeed for sure.
Okay. The next question is, who pays for the vocational assessments? And what do you do in communities where there aren't, and I apologize that I said Edmonton when it's Calgary. What do you do, who pays for your assessment work? Is it covered by provincial insurance, or do clients or employers have to output that responsibility themselves?
Yeah, so Gerard and I both work for Alberta Health Services, so we're funded through the public healthcare system. That being said, often if clients have access to long-term disability benefits, there are people that function in a very similar role to what Gerard and I do. That being said, again, it's always being aware of what their role in the team is, like what their agenda is, as Gerard kind of went over in his slides.
I was thinking the viewpoint of the services from someone who, like Sam and I, actually kind of deliver the return to work planning from soup to nuts, but a lot of times, as Sam was saying, there's other resources available through the insurer or even the employer, occupational health and safety. And our responsibility might be just to provide all the information that provider needs in order to make the return to work successful.
Great. Alan, the next question is for you. Why did the metrics for stroke survivors drop from year +1 to year +3?
Sorry, can you repeat that question?
Why did the metrics for stroke survivors drop from year +1 to year +3?
Okay, can we go to that slide? Can you navigate us to that slide, the first set of graphs?
Lisa, can you do that?
Yeah. So whoever's got control of the slide set at the moment, you could just, I'll tell you when to stop. Keep going back. Keep going. I'm sorry, go forward. Go forward from there. Go one slide at a time. Keep going. Keep going. There it is. Nope, that was it. Those two graphs. Okay. So the question, I think, was, why is there a continued fall in work from the first year after, which is Y+1, to Y+2 to Y+3? And you see that, in fact, the difference between the two curves is getting wider with time. So I think that the answer here is that there are some people who try to go back to work and then they fail, as the other presenters discussed, as it doesn't always succeed. So people tried. You see how that for instance, at 1 year after, 75% of people who had previously been working were no longer were working. So the loss was 25%. And then it goes down with time, and it goes down faster on that left curve than it does for the controls, which are the ones with the black circles. So again, I think it just means that people are trying and failing.
And follow up to that question, was an interesting one, and this is some research that came out that we were promoting last year, is that often after a stroke, couples will break up. Was there any way to quantify or to factor in potential marriage breakups or separations during that time that may account for changes in return to work?
Yeah, that's a really interesting question. When we first started designing this study and planning it, we realized that that was an intriguing outcome to look at changes in marital status related to these events. We finally decided that it was too much for this one project. We couldn't do that as well. It is an interesting question. When we looked at the spousal data that I showed you, that was only limited to people who remained married to the same person from before to 3 years after. It does not include people who might be married to a different spouse or whose marriages broke up. It's for the people whose marriage was stable from Y-1 to Y+3. Those are additional questions that are interesting too, but we didn't answer them.
Great. And there was some research out last year that said if the woman has the event, there's a higher chance of marital breakup than if the male partner has the event. So that might be an interesting factor.
Yep, that would be interesting. Again,
another question over for Sam and Gerard. How long is your process to address return to work? How often do you see your client? And how far post event does the majority of your clients able to return to work?
That's a multi question there. I mean, our program, the CAR program is a fairly short term program. It will go around about 12 weeks, but the return to work plan can take up to 20 weeks, and it generally doesn't start until the end of it. So we tend to keep those clients on that we're helping go back to work. They're typically, I don't know about when we see them from date of event, but generally a couple of months. They've already gone through an early supported discharge program in the community, been discharged from the hospital, gone to that outpatient program, and then on to us. And so we would tend to be more involved in the return to work plan as they kind of come to the end of their regular treatment with the other therapists, like the speech therapists and physios and OTs. I don't know if that answers it very well, if that was confusing.
No, I think, and then building on that, can you comment at all on post-cardiac event, post-stenting or CABG patients as well, or is your work mainly focused within stroke?
Yeah, our focus is primarily stroke and head injury, yeah.
So for all of, yeah, go ahead, Alan.
Is that we did look, I didn't show the data, but we did look at whether there was a difference in the impact on worker earnings of revascularization for the heart attacks, whether people got cardiac catheterizations in their initial hospitalization, and whether they got revascularized with a stent or an angioplasty or a bypass surgery, again, limited to their initial hospitalization. And to our surprise, none of those made a difference. We thought it would be very interesting if we found that people who were treated more aggressively in their index hospitalization had differential return to work, but we didn't find that.
Thank you. And then to all of you, and I'm not sure, maybe we'll start with Alan and then move the same question over to Sam and Gary. Is there a difference in potential to go back to work or actually getting back to work and being successful if the stroke injury was on the left brain or versus right brain?
No. Well, we didn't look at that. We did look at bleeding strokes versus ischemic strokes, hemorrhagic ischemic strokes, and there was a little bit of difference in the direction that you'd expect. It's been known for a long time that hemorrhagic stroke patients have more debility after amongst survivors than people with ischemic stroke. So there was a little difference there, but we didn't look at left versus right. And you'd have to look at really dominant hemisphere, right, as opposed to just left versus right.
So Gerard and Sam, in your practice, do you see a difference?
We haven't noticed a difference. That being said, in terms of functional abilities, certainly the clients that have communication issues, So whether that's expressive or receptive, and whether that's in writing or in speaking, those clients definitely struggle much more with return to work and success with return to work, because it's almost impossible to get away from any job without communication demands.
So on that note, we know that aphasia is a significant issue in patients with stroke. What are your success factors, or what are the key things to help a person who is aphasic to some degree in returning to work?
I mean, certainly we would defer a lot to our speech therapy colleagues for that, but we try to come up with practical strategies that are going to work for the client as well as for the employer. So again, when we ask for accommodations like things in writing, or for the client to be able to respond to things in email versus verbally, these types of strategies, and then of course being provided with extra time for people to respond. So we try to do our best that way. That being said, a lot of it is up to the individual job and the supportiveness of the employer in terms of working with that client.
Okay. Sorry, was somebody else going to comment in there? I thought I heard someone coming in. Okay, next question, and I think we'll wrap it up after this. In terms of assessments for return to work, are there preferred questionnaires or tools you use that focus more on the physical and ones that focus more on the cognitive?
Well, I know that the stroke best practices mentions a thorough neuropsychological assessment. We don't always have that done. A lot of times we do, and we would focus on the kind of the barriers that affect that person's individual job performance. For the physical assessment, we have tended to do a sort of a modified functional capacity evaluation, but it's a fairly simple model. In the case where that person's job is very physical. Generally, we count a lot on the input from the other team members, the OT, the speech therapist, and the physio, to give us a lot of information about the person's functional ability.
Sorry.
Hello? Yeah.
Yep.
And just to build on what Gerardo was saying, again, what we try to do is really try to go over what is a client doing currently in terms of their functional activities. So we've done a lot of trying to figure out where they're at, both in terms of physical and cognitive demands, based on their performance of their, whether they're driving their kids to school every day, and are they able to stay on schedule. In terms of their physical demands, are they doing a lot of yard work? Are they taking out the garbage every week? Approximately how heavy is that garbage? Like, do you have stairs in your house? So a lot of it really is through that interpretation of their regular activities that they're currently doing. And then we try to estimate from there, what they could potentially do. And that's I think that's the other big role in terms of having that physician clearance for the return to work plan. When we write down that a client could return to, lifting 10 to 20 pounds on a frequent basis, for example, that's where, again, like that, the role of the physician really helps to support that, or to highlight that's not safe. We need to back off on that sort of thing.
And there's actually one final question that I'll sneak in because I think it's really important. Is there a requirement for people to report to their employers when they have a health issue? And how do you deal with patients who say, oh, I don't want my employer to know because it'll jeopardize my job and I'm just going to take some time off? Is there requirements, and does that vary by private sector versus public sector? Do you know?
No, I think we've told people in the past that if they can honestly say that they can do the job successfully, they're under no obligation to highlight a medical condition. But they have to be they'd have to be honest with that and say, well, there's nothing impeding my ability to do the job. Certainly that comes up with new employers. Old employers almost always know. They visited the person in the hospital, or they've done, so they're always, somehow they know more information than they should. But so it's kind of hard to hide that stuff.
Okay, well, we'll end it there. And I want to thank all of our presenters. You're amazing. The information was so helpful and so practical from all of you. So Gerard and Samuel, Alan, thank you so much for your time. Thank you to all of our audience for watching and continuing to support the Stroke Best Practice webinars, which will now expand also to include areas of heart disease and vascular cognitive impairment. We do have a heart failure webinar coming up in May, on May 7th, and also an invitation for everybody to come and join us at Stroke Congress in October. So thank you again to everyone for participating today. This will be made available online in a few days, and we encourage you to please go in and complete the evaluations when the link comes, because that helps us to make sure that the topics we present are ones that matter to you. So thank you, everybody. Have a great rest of the week.